So our next speaker is Dr. Hosogane, our former colleague from Keio University. Now he is the chief of orthopedic department in Keion University, and he contributes significantly in our ISSG research, International Research Society meetings. Thank you for being here. And he's going to give us talk on surgical result of adult spinal deformity patients treated with lateral interbody fusion combined with posterior fusion.
It's a great honor to attend this symposium and present our study today. And also, I'm very happy to meet our old friends. I'd like to thank the organizing committee. My name is Naobumi Hosogane from Keio University, which is located in Tokyo, Japan. Today, I'd like to talk about surgical result of adult spinal deformity patient treated with lateral interbody fusion. This is my disclosure. First of all, I'd like to ask the audience about surgical planning for this patient. This is 68-year-old female who is a typical Japanese ST patient. She has no history of previous spine surgery. She had 40 degrees of lumbar curve with the severe surgical deformity, with 20 degrees of the lumbar kyphosis, with a PI-LL of 65 degrees. She has no spinal canal stenosis, and she does not have any symptoms in the leg. She has the low back pain with the imbalance in the surgical imbalance on the colon imbalance. Hyperextended film shows that her lumbar lordosis increased to 6 degrees. However, only to 6 degrees, and the remaining the PI-LL mismatch up to 40 degrees. So I thought I have to include the ALS question, so I prepared these slides. But I heard that we don't have this system today. So what is your surgical planning for this patient? Is it only the correction with the posterolateral fusion alone? Or is it combined with the multi-level lumbar prefrontal lift? Or is it combined with the three-column osteotomy such as PSO and VCL? Or is it combination with the lateral interbody fusion? Please raise your hand if you choose plan A. PSF only? Okay. How about the B, combined with multi-level prefrontal lift at the lumbar spine? No. Okay. How about the C, three-column osteotomy? Okay. How about D, combination with the lateral interbody fusion? Okay. Thank you. So before start talking about the lateral interbody fusion, I'd like to briefly introduce about the ASD features of the Japanese ASD patients. So as you may know, Japanese are very skinny. This slide shows the distribution of the prevalence of the adult obesity who has the BMI over the 30. You can see that prevalence in US is 9 times as high compared to Japan. Also, this slide shows the average height in female. You can see that Asia, including Japan, has lighter red, which means short height, whereas in Europe and US has the darker red, which means higher height. So there's some differences in body shape and size around the world. Raising the question, is spine morphology in SD patients different? So to answer to this question, we conducted the collaboration study with the International Spine Study Group a while ago. We have compared the patient between US and Japanese SD patient who had the correction surgery with minimum 2 years follow-up and who were older than 50 years of age, using the same inclusion criteria of the ISSG, as you can see in slide, in both groups, and obtained 211 patients from North America and compared with the 71 patients from Japan. So comparison of demographics of the patients shows that SR-Schwab ASD classification curve type distribution were very similar between these two groups. In terms of the radiological parameters at baseline, you can see in the corner plane, lumbar curve angle were almost identical over the 40 degrees, which means that both groups had the large lumbar deformity. However, in such a plane, all of these parameters, such as lumbar lordosis, PI-LL mismatch, and SVA, were much worse in Japanese patient compared to the US patient. Especially the lumbar lordosis very small in Japanese patient, which may result in the higher PI-LL. So the typical Japanese patient has a very low flat back associated with the degenerated discs compared to the US patient who had a substantial lumbar lordosis. The other big differences between US and Japan is the rate of the previous spine surgery, which is exceeding 20% US patients, whereas only 4% in Japanese patients. So the features of the ASD patient in Japan is that we have predominantly elderly patient with such an imbalance with a flat back associated with severe disc degeneration. So for this kind of patient, it may require the interbody fusion to restore disc height and lumbar lordosis. Also, as we have a very low rate of history of previous spinal fusion, we don't have to worry about the fusion mass osteotomies. So based on these backgrounds, the posterior collection with multi-level proof TLIF at the lumbar spine to the sacrum has been the mainstream method in Japan until 2013 when we introduced the XS ORIF into Japan. So as you may know, the potential advantages of LIF for the ASD patient may include that we can achieve the multiple interbody fusion with less invasion, and also we can get a better correction in colon plane with the sufficient interbody release from the lateral axis. And also we can get a better correction and maintenance in the sagittal plane, which may due to the larger cage, which may prevent the case subsidence. So we changed our strategy from one-stage posterior fusion with the multiple proof and TLIF at the lumbar spine to two-stage surgery, starting with a lateral interbody fusion at mid to lower lumbar spine, usually at T2 to L5, and followed by the posterior spinal fusion, adding the PLIF at L5S1, which is the X-RIF and ORIF are not applicable. So the question of this study is that does LIF really have the advantage over the conventional method in Japanese ASD patients? There are several studies that evaluated the efficacy of lateral interbody fusion in the ASD patients, such as study from the Tormenti, or the study from the Wang, or the study from the Phillips. All of these studies show that good collection in the colon plane, such as 70% from the Tormenti study or 60% from the Yang study. However, lumbar lordosis restoration is somewhat limited. No improvement in the lumbar lordosis in Tormenti study, only 10 degrees of restoration in the Wang or Phillips study. Also, there are various methods are combined with the lateral interbody fusion, such as open PSF in Tormenti or PPS and Wang, or the lateral plate or unilateral particle screws in Phillips. So there is other several studies that compared the patient who had a PSF alone or the combination with LIF in the ASD patients, such as a study from Hack and Strom. If you look at these studies, there is some differences in the fusion lengths, such as study in HARC, or the no interbody fusion in PSF alone group is used in the study from Strom, which is different from the typical PSF strategy in Japan. Also, if you look at the baseline radiological parameters, the sagittal deformity was somewhat mild compared to the Japanese ASD patient, such as the PI minus LL is around 20 degrees. Also, there is some differences in degree of the deformity at baseline, such as cobble angle in the study from HARC or lumbar lordosis study from the HARC. Also, there is other study from the theologists who compare the patient who had a PSF only, which is the patient who had a PRIF at L5S1 only, and compared with the patient who had a PRIF at L5S1 and added a LIF at the apex, 16 patients in each group, which were matched for the fusion lengths among 1,200 patients, and shows that collection of cobble angle were significantly better in the LIF group, which may be attributed to the adding the LIF at the apex. However, post-op LL were not significantly changed between these groups. Also, the major complications were more frequently occurred in the LIF group compared to the PSF group. However, in this group, PSF group only had interbody fusion at L5S1, which is the not identical surgical strategy between these two groups. So we did the comparison study with propensity score matching. So we propensity score match for the patient for the age, gender, SR-Schwab classification curve type, and the severity of deformity such as baseline lumbar cobble angle and PI minus LL among the 112 patients in the multi-center database, and obtained 41 patients in the conventional group who had an open PSF with a multi-level proof TLF at the lumbar spine to the sacrum, and compared with a patient who had a lift at the mid to lower lumbar spine, followed by the open PSF, adding the L5S1 proof. So comparison of the demographics of these patients revealed that age, gender, Schwab curve type classification were identical between these two groups. Also, lumbar curve angle at baseline were nearly 40 degrees in both groups, and PI minus LL at baseline were exceeding 40 degrees in both groups, which means that these patients had the severe deformity both at coronal and sagittal plane. The number of fused segments were almost identical, 9 levels in both groups. And number of interbody fusion were 1.5 level more in the lift group compared to the conventional group. And if you look at the level of the interbody fusion done, you can see that more interbody fusion is done in the upper lumbar spine in the lift group compared to the conventional group. So in terms of surgical invasion, surgical time were significantly longer in lift group, which may be due to the two-stage surgery. However, EBL were slightly decreased, although not statistically significant, despite of longer surgical time or more interbody fusion done in the lift group. In the coronal plane, lumbar curve angle were significantly improved after the surgery in both groups without any intergroup differences. However, if you look at the correction rate, lift group had a 69% of the correction rate, which was marginally significant different compared to the conventional group, which was 62%. In the sagittal plane, lumbar lordosis significantly improved after the surgery in both groups, and the lift group had a significantly better lumbar lordosis at the final follow-up compared to the conventional group. Comparison of pelvic parameters shows that pelvic tilt and sacral slope both improved after the surgery in both groups, and the tendency to have the better value in the lift group after the surgery with some significant difference. SVA also improved after the surgery in both groups, and at the final follow-up, a lift group had a significantly smaller SVA compared to the conventional group. Finally, PI minus LL also improved after the surgery significantly in both groups, and the lift group had a better PI minus LL at the post-op and also the final follow-up. The percentage of the patient who required the PSO to get the enough correction was 17% in the conventional group, which was only 2.4% in the lift group, which was statistically significant different. This is a case example from the conventional group, 73-year-old female who had 30 degrees of the lumbar curve and 5 degrees of the lumbar kyphosis with the PI minus LL 57 degrees. Hyperextending film shows that lumbar lordosis improved to 17 degrees, but the remaining PI-LL mismatch was up to 40 degrees. So this patient was performed before the introduction of a lift. So we thought that it's not easy to correct only with the peripheral TLIF. So we plan to do the 3-column osteotomy. So we did the L2 PSO, resulting in the good correction in the coronal plane and sagittal plane. This is the patient from the lift group. This is a case that I have showed in the very first slide. She has the 40 degrees of the lumbar curve and 20 degrees of lumbar kyphosis, the PI minus LL 65 degrees, so severe than the previous case. And the hyperextending film shows that lumbar lordosis improved only to 6 degrees. Remaining PI-LL mismatch was up to 40 degrees, so very similar to the previous case. So for this case, we have done the 3-level exercise first, improving the 20 degrees lumbar kyphosis to the 10 degrees of lumbar lordosis. We saw the 30 degrees of corrections. And 1 week later, we did the posterior fusion from T9 to the sacrum with adding the L5S1 prep, resulting in the good coronal and sagittal correction. So compared to the previous case, we could get the equivalent correction without doing the 3-column osteotomy. So there are several studies that have compared the patient who had a lift and the conventional PSF. The recent study from Yang he did the systematic review, including 621 patients from the 10 studies, and compared the patient who had a different conventional PSF, and showed that sagittal collection, corneal collection, and the pseudo-resources rate and health-related quality of life were significantly better in the lift group compared to the conventional group. However, the disadvantage of the lift group included the larger surgical invasion or more neurological complication, which may be due to the lateral access. So another study from Japan, which evaluated the ASD patient with a severe lumbar sagittal deformity and compared the patient who had a lift on the cerebral osteotomy, and showed that PI-LL and SBA were significantly better in the lift group compared to the cerebral osteotomy group. So in this study, we have propensity score match for the patient demographics and baseline sagittal and corneal deformity. And we only included the severe deformity with the lumbar curve nearly 40 degrees and the PI-LL over 40 degrees. And shows that lift group had a significantly better correction rate of the lumbar curve angle and better final lumbar lordosis and PI-LL. So thinking about the efficacy of lift in the sagittal plane, with a patient who had a severe flat back with a severe disc space narrowing, such as ASD patient in Japan, which may be difficult to collect and maintain the disc space with the small cages, such as with the T-less and pull lift. So we need to do the collection with the PSO. On the other hand, using the lift, we may be able to collect with the large footprint cages for the multi-level without additional invasion. And by adding the grade 1 to 2 osteotomy from posterior, we can get the equivalent collection without doing the PSO. Also, in the corner plane, we sometimes see the rigid deformity with a breaching osteophytes, such as these patients. And for this kind of patient, it may be difficult to release sufficiently from the posterior. However, with using the lift, we can able to release directly from the lateral. And also, we are able to perform to upper lumbar spine, which may result in the good collection in the corner plane. So the limitation of the lift may include that we cannot do the complete release for the patient who has a completely fused vertebral body. Also, for the patient who has the vertebral deformity, it may be difficult to collect only with the lift. So this patient may require the cerebral osteotomy. So to summarize my talk, the efficacy of using lift was evaluated by comparing with the conventional posterior-only approach in Japanese ASD patient with flat back. So correction of lumbar curve tended to be better in the lift group without additional surgical invasion such as EVL. And in such a plane, better correction of lumbar lordosis, SBA, or PI-LL were able to obtain with the less application of PSO. Our results suggest that favorable alignments were able to obtain with less invasive surgery by combination with lift. However, the overall efficacy of lift should be determined with further study evaluating the clinical outcomes or complications related to the lateral approach and economical standpoint. Thank you for attention.